Good afternoon. Julián Castro was sworn in as the 16th Secretary of the U.S. Department of Housing and Urban Development in July of 2014. In this role, Secretary Castro oversees 8,000 employees and a budget of $46 billion. Secretary Castro uses a performance-driven approach to help achieve the department's mission of expanding opportunity for all Americans. Under Secretary Castro's leadership, the Federal Housing Administration lowered mortgage insurance premiums to make home ownership more affordable for responsible families. HUD also released its new Affirmatively Furthering Fair Housing Rule to fulfill the full promise of the Fair Housing Act, helping families access strong neighborhoods with housing choice vouchers and empowering local leaders with new tools to invest in their communities. Before HUD, Secretary Castro served as the mayor of the city of San Antonio. Secretary Castro was named to the World Economic Forum's list of young global leaders in 2010, and he has been included in Time Magazine's 40 Under 40 list of rising stars in American politics. Please join me in welcoming Secretary Castro.
Good afternoon. First of all, thank you so much, Judge Keller. It's good to be with a fellow Texan, and thank you for your work on this effort. I know that it's having a national impact. I also want to thank our partners at the Council of State Governments Justice Center, including Dr. Nicole Jarrett, as well as the Bureau of Justice Assistance, for hosting this important gathering. I also want to give a shout out to three leaders that I'm honored to share the stage with today. Melissa Harris of the Centers for Medicare and Medicaid Services, Gabrielle de la Gueronniere of the Legal Action Center. Did I get that right? Kind of right. And Andy McMahon of the Corporation for Supportive Housing. Each of them is doing tremendous work to break the cycle of incarceration that traps too many of our fellow Americans. How's everybody doing? Where are folks from? We have anybody from California? How about Illinois? Yeah? How about New York? New Jersey? You can always count on the New Jersey folks to be loud. How about Texas? Is anybody here from like Wyoming or anything? All right. Well, wherever you're from, welcome to Washington, D.C. We made the weather good for you. Traveling for work is rarely easy, and that's especially true around the holidays. I hope everybody has gotten their holiday shopping done. But please know how grateful I am, and everyone is here, that you've made the time to be here to share your insight with your fellow travelers and colleagues who are helping to make our justice system fairer for all Americans. From one generation to the next, America has been known across the world as the land of opportunity, and for very good reason. Through the years, there's been no better place for those willing to apply their talent with hard work, determination, and imagination to reach their dreams. Today, as we head into 2016, the question that we face is, how do we ensure that America remains the undisputed land of opportunity in this 21st century? Moving forward, part of the answer is that we have to recognize that opportunity doesn't mean much if it isn't also extended to those who have made mistakes in life along the way. Every year, more than 600,000 of our fellow Americans are released from jail or prison. Some of them were failed early in their lives. They never really had a chance in the first place. Some of them failed themselves. but all deserve a chance to go as far as their dreams and their hard work will take them. And the work that you do as part of the Second Chance Act to help returning citizens become productive, thriving members of their communities, once they've paid their debt to society, is transforming lives, it's making our nation safer, and driving greater American prosperity in these years. So please give yourselves a big round of applause for the work that you're doing in local communities throughout our nation. We appreciate it. As you know, this session is all about how we can work together in ways that improve the odds for folks returning from jail or prison. And it won't come as any surprise that I'm convinced that housing has a fundamental role to play in helping them succeed after they get out. That includes folks like 31-year-old Darnell Smith, who served 10 years in upstate New York's Sing Sing Correctional Facility. When Darnell was released, his wife and children were eager to reunite with him. But his family lived in New York City's public housing, which until recently barred folks who'd served time or who'd even been arrested from living in NYCHA apartments. Leaving their public housing just wasn't an option for Darnell's wife. So Darnell considered living in a homeless shelter before he finally secured a room in Harlem to the tune of $600 a month, money that we all know would have gone a long way toward paying his family's rent if they'd been allowed to live under the same roof. Fortunately, after 2 long years, Darnell was able to take advantage of a pilot effort that's allowing some returning citizens to move into public housing. It's a partnership among the Housing Authority, the Vera Institute of Justice, the city's Department of Homeless Services, and the Corporation for Supportive Housing. In addition to lowering the barrier to securing a home, the initiative connects folks like Darnell to case management and other reentry services. And importantly, it allows them to add their names to the lease at the end of 2 years, something that's going to make a big difference in ensuring that they can continue to succeed long after the program ends. HUD supports these efforts. We're also working to ensure that folks aren't denied housing opportunities simply because they've had contact with the criminal justice system. That's why last month we announced new guidance to housing authorities to let them know that arrest records should not be used to keep folks from securing a home. We've also ended the decades-old one-strike policy for people arrested for drug offenses. It used to be that if someone was arrested for a drug offense, their entire family would be kicked out of public housing. It was a harsh policy that likely did more harm than good. So now we're taking a new approach in how we handle lease violations. Local officials will still have the ability to evict folks when their actions warrant it, but families who pose no risk to community safety won't be unduly punished. That way, we'll ensure our focus remains on the people who count on us most. These latest steps are part of President Obama's renewed effort to help formerly incarcerated Americans successfully reintegrate into their neighborhoods. And they're going to help move the needle for a number of communities who are making housing support for returning citizens a real priority. One of those communities is Chicago. There, the Housing Authority has launched an effort similar to New York's to give folks a meaningful second chance. In Burlington, Vermont, they've created a corps of reentry housing specialists whose job it is to help parolees locate private or subsidized housing. In King County, Washington, HUD's partners have launched an effort specifically for parents leaving state prison to help them reunite with their children. Participants spend 18 to 24 months in a residential supportive housing community called Passage Point, and then they have the option of moving into conventional public housing. And up the road in Baltimore, officials are working together to tackle recidivism by focusing on homelessness. We know from research and experience that incarceration and homelessness often function together in a kind of revolving door of risk. As many as half of all homeless Americans have a history of incarceration. And not having a stable home is one of the greatest risk factors that someone will become incarcerated. So Baltimore's Housing Authority has set aside 200 housing vouchers specifically for chronically homeless citizens who have served time. We're proud of that effort. There's a growing consensus that investing in permanent supportive housing is one of the very best ways to help break the cycle between homelessness and incarceration. And it's part of a larger movement calling for an end to the criminalization of homelessness, a movement that HUD fully supports. For tens of thousands of men and women returning home from incarceration, the question of where to live presents an immediate and at times desperate concern that's in our entire nation's interest to address effectively. And I want you to know that my team at HUD is committed to working with you every step of the way to ensure that we're lowering and, when possible, eliminating the barrier to housing for more returning citizens so that they can get the second chance that they need. Of course, everyone in this room also knows that housing alone is not enough. After all, what good is securing a home if you don't have the means to maintain it? We've got to redouble our efforts to connect more returning citizens to jobs. So we need to expand job training efforts for folks who have served time. And we need to ban the box so that formerly incarcerated citizens get a fair chance to compete for jobs once their training ends. A number of cities, states, and private companies have already banned the box, and President Obama is calling on Congress to do the same for all federal hiring as well. And in the meantime, at HUD, we're not standing still. We're acting. We're investing nearly $2 million to help young public housing residents who have run afoul of the law expunge their criminal records, something that'll help them find work and then give them a better shot at turning their lives around. We're also committed to working with our partners at HHS and at the Centers for Medicare and Medicaid Services to connect more Americans to the health care and especially the mental health services that we know can make such a difference in their lives. Often, even when someone who's served time has a stable home and completed job training, their job search can be hampered by untreated addiction, by mental illness, or even chronic conditions like HIV. Fortunately, thousands of formerly incarcerated citizens are obtaining health care as part of the Affordable Care Act's Medicaid expansion. And we want to work with the Second Chance Act grantees to do whatever we can to ensure that more Americans get the health care that they deserve. 50 years ago, President Lyndon Johnson said that citizenship is only as valuable as every citizen's ability to participate fully in our society. Citizenship, President Johnson said, quote, requires a decent home and the chance to find a job and the opportunity to escape from the clutches of poverty. And he said it is both in our national interest and our nation's responsibility to open the gates to opportunity while also giving every American the help that they need to walk through those gates. With your continued partnership, we'll fulfill that promise and we'll open wide the gates of opportunity to every citizen, no matter what they look like, where they come from, how much they earn, or whether or not they've spent time inside a prison cell. Thank you for your impactful work. We applaud you. Keep it up. Thank you.
Thank you, Secretary Castro. Inspiring words all day. I hope you've really caught on the energy of this national movement that we're all part of. And he really set us up for our plenary that we're about to enter into right now. I'm Nicole Jarrett. I oversee grantee technical assistance. I've worked with Justice Mental Health Collaboration Program grantees as well as Second Chance Act grantees. And one of the topics that come up all the time is how challenging it is to get housing for people returning, as well as health and health care. So we decided to discuss this on the last plenary of the day. And I'm really happy to be joined by my panelists here. We're going to talk about health and housing in two parts. So the first part, we're going to talk about housing, and I'm going to ask Andy McMahon to really reflect on Secretary Castro's earlier remarks. Andy is the Managing Director of Government Affairs and Innovations at the Corporation of Supportive Housing, and he oversees the Federal Policy Team, Strategic Initiatives Team, and the Research Team, and he will be able to talk a lot about what this really looks like, the federal resource and what that looks like on the ground, what the challenges are, what are the additional opportunities that Secretary Castro didn't have a chance to address in his opening remarks. And then the second part of the plenary, we're going to turn over and talk about health care. And we're going to start off with Melissa Harris, who is the Acting Deputy Director of Disabled and Elderly Health Program Groups at the Centers for Medicare and Medicaid Services. And then she will be followed by Gabrielle Gueronniere at the Legal Action Center. She's the Director of Policy there, and she'll talk about how, again, the federal resources around healthcare policy and the new initiatives, again, what they look like on the ground. So with that said, let me first turn it over to you, Andy. Could you speak to what you're finding as the biggest challenges that folks that are working to end the cycle of housing and incarceration, what the challenges are, and what are the opportunities, and how best can programs take advantage of the resources that Secretary Castro referred to earlier?
Great, thank you. Thank you very much, and thanks to all of you for having me. As she mentioned, my name is Andy McMahon, and I'm from CSH. We're a national nonprofit that has been around for about 25 years, working in communities to connect the dots between housing and other supports that people need to live and thrive in the community. Before I talk a bit about our approach and opportunities in working with all of you, I want a huge thank you to Secretary Castro for his incredible leadership and vision and commitment on this issue. We've worked with his office really since he came in, and we could not ask for a stronger, better partner out of the U.S. Housing and Urban Development Office than Secretary Castro. So a huge thank you to him, and also thanks to our friends at DOJ and BJA for all of the great work that you all are doing, and CSG to lead this. And I also want to say at the outset, working with a number of you all as grantees across our organization, we're incredibly thankful and indebted for the incredible work that all of you all do every day. I'd like to talk a little bit about kind of the challenges that we certainly see, and then, but really focus more on where we see the solutions. And I think in looking at this plenary and thinking about kind of cross-system efforts, I'll speak about supportive housing and how, from our perspective, it embodies the integration of programs and policies and resources to a T. As Secretary Castro said, certainly from the work that we're doing in dozens of communities across the country, there is an enormous shortage of both supply of safe, decent, affordable housing, so sheer supply as well as access to, and that's one of the things that the Secretary spoke to that I think his leadership has been incredible. And I can tell you at CSH and with a number of our partners, we are working with public housing agencies across the country, with state housing finance agencies, in efforts to reduce the barriers to access to safe, decent, affordable housing, to great success in working with folks at the Council of Large Public Housing Authorities and other partners to really try to promote and increase access to housing. As Secretary Castro mentioned also, I think for CSH, there's a huge intersection there between the need for safe, decent, affordable housing, but also the fact that so many of the folks returning from our communities also suffer from an array of health conditions, be they primary care or behavioral health care, including mental illness and addiction, and sometimes a confluence of all of those things that creates additional challenges to them, both in terms of securing housing as well as securing income through jobs and accessing benefits as necessary. Excuse me. So at CSH, our cross-system approach to addressing these issues, when we think about the myriad issues that people have of getting access to safe, decent housing, but needing necessary, mental health care or addiction services or primary health care services, is creating supportive housing in communities across the country. So supportive housing that people exiting and diverted from the criminal justice system links them with a safe, decent, affordable place to live, but also links them with providers in the community, behavioral health and primary health care providers, to ensure that they can stabilize their lives and expand their opportunity for themselves in the community. I'd like to briefly just talk about Jeffrey, who's somebody in my hometown of Minneapolis who had gone, again, as the Secretary alluded to, through this cycle of homelessness and incarceration, and finally was so fed up and talked to his probation officer, who linked him up with St. Stephen's Human Services in South Minneapolis, where he was connected to the housing and the supports that he needed. And not surprising to anyone in this room, about less than 1 year later, Jeffrey was thriving in the community. He was a volunteer at the Hennepin County Drug Court doing orientations. He became a caretaker of the apartment building he was in, and he got a job. The question I think I often get asked is, well, how did that happen, and why does that work for so many people? And I will be brief, but I want to mention that from our perspective, the magic, if you will, is in the fact that supportive housing itself is both a integrated systemic or policy response to this issue, as well as a practice or program response. As we look to create supportive housing in communities across the country, we are working with public housing agencies. We're working with state housing finance agencies. We're working with state Medicaid agencies and their partners at CMS. And we're engaging with the behavioral health system and workforce investment boards, WIBs, and others, and including, I should say really importantly, including parole and probation in our efforts. So when we create these interdisciplinary teams of providers that are assisting people, we bring parole and probation onto the team, which creates an integrated response that really, from our perspective, has worked well. I'm just going to mention one quick program, and then I will stop there. But we have engaged with our friends and partners. I don't think the Secretary called out Ohio. Do we have anyone from Ohio in the room? All right, great. So we're working with the great folks in Ohio and the Ohio Department of Rehabilitation and Corrections on an initiative called Returning Home Ohio. And it's been an incredible partnership that focuses on targeting individuals who are at high risk of homelessness with disabling health conditions who are exiting the state prison system. And we're connecting those people to a network of housing and supportive services providers in the community. And it's working. Through a rigorous quasi-experimental evaluation, we've seen returning home Ohio participants 60% less likely to be reincarcerated, 40% less likely to be rearrested for any crime, and they are accessing 3 times as many services and supports in the community to help them stabilize and thrive. So I'm going to stop there, but really appreciate the opportunity to be with you all here today, and again applaud the incredible work that all of you all are doing in trying to kind of figure out how we develop and create these integrated responses so that we can stop this cycle of incarceration and reincarceration. Thank you.
We're not done with you. I just had a follow-up question. I mean, and I'm really excited to hear about what's happening in Ohio and this integrated response. And I'm curious about how do you actually get to that point for a jurisdiction or a state that is really interested in bridging that gap and perhaps replicating something that the Ohio Returning Home program. What would you recommend? Where should folks begin?
So I would probably start with data and collaboration. So data on the first piece of this puzzle. One of the things we've done in Ohio and communities across the country is look at and analyze data across systems so that we can understand and actually see the prevalence and the scope of the problem, and see when you look at people who are returning to jails and prisons and looking at the fact that they're also in our homeless systems and they're also clogging up our behavioral health system. So really doing that data piece on the front end that from our perspective shows each of these agencies that needs to be brought to the table that this is a shared quote unquote problem and we're not going to get there by any single response. And so by doing that data analysis and being able to show how interrelated and interconnected these issues are, and that the folks exiting the prison or the jail are the same folks who are going in and out of the homeless shelter and the same folks who are going in and out of behavioral health care and detox, and painting that picture and then bringing those key agencies to the table and beginning the conversation about the roles that each of them can play, the resources that each of them could bring to the table, and the expertise that each of their agencies bring. Again, for us, it is that kind of integrated, collaborative response that is the way to success.
Okay, great. Thank you. So I'm going to shift gears a little bit and talk a little bit about healthcare. But first, we have a polling question. And so these polling questions should be on your app. Hopefully all of you have your app. And this is what the question is. Since state and federal changes to healthcare policy, have you seen any change in the number of people in reentry enrolled with healthcare coverage? So we have this massive policy change. What does that look like? What have you seen? A significant increase of more than 20%, only a slight increase under 10%, no increase at all. Things haven't really changed as far as you're concerned, and you really don't know. So we'll check back on your responses, but please weigh in. We'd love to hear what you're experiencing. And with that, let me turn to you, Melissa. Healthcare has been mentioned a few times already, which is exciting. And we know about ACA, massive changes to healthcare coverage. I think there's still probably a little bit of mystery about what's happening where, because we know in different states it has rolled out differently. Could you tell us more about what the key resources are now and what we should be aware of as we're trying to serve people coming out of the criminal justice system?
Sure, and thank you very much for having me. I'm quite excited to be part of the conference this afternoon. I am Melissa Harris, and I'm from the Centers for Medicare and Medicaid Services. We're in the Department of Health and Human Services, and my agency administers the Medicare, Medicaid programs, as well as the private insurance markets that were established under the Affordable Care Act. So one of the topics that has been of great interest across the federal government and certainly within the Department of Health and Human Services and within CMS specifically is this issue of individuals who are beneficiaries of any of those three programs who are incarcerated. And as they are getting ready to reenter their communities, what is the role of healthcare, and I'm talking regardless of what kind of health insurance this individual has, in making sure that the gaps are minimized between when the individual is released and when he or she can directly access healthcare. And then specifically within the Medicaid context, working through what is the relationship between Medicaid, which is a joint federal-state partnership, and the Departments of Corrections that are across the states as well. And so as we have been working to draw with more clarity the parameters around Medicaid reimbursement for individuals who are incarcerated, there are a couple of things that we should all be aware of. And these are part of our legislative landscape in the Medicaid program and have been really since its inception in 1965. If you look in the Social Security Act, specifically in Title 19, which is the Medicaid legislation, you'll find a definition of medical assistance, which defines the menu of services that are coverable under the Medicaid program. Some are mandatory that have to be provided across all states and across all Medicaid populations. Others are optional and at state discretion to offer in the Medicaid program. But then if you look at the bottom of that list of covered services, you'll find two scenarios that medical assistance does not cover and are in fact excluded from Medicaid coverage. And one of those scenarios is services provided to an individual who is an inmate of a public institution. There is an exception to that payment exclusion, though, and the exception is when that individual is a patient in a medical institution, federal dollars are allowed to flow for those inpatient medical services. But otherwise, if the Medicaid beneficiary is incarcerated, then there is no federal payment. So within that context, CMS years ago embarked on issuing some guidance that tried to flesh out that payment exclusion a bit more and also tried to flesh out the exception to the payment exclusion. And in 1997, we issued some guidance that walked through the scenarios in which federal Medicaid reimbursement was and was not available. And that guidance did the trick for some years, but upon the passage of the Affordable Care Act, and particularly the expansion of the Medicaid program to childless adults, as this population is often called, from 0 to 133% of the federal poverty level, states became aware that a good chunk of their population of individuals who are incarcerated would become eligible for Medicaid upon the state expanding its Medicaid program. And so states started coming to us saying we need to reinvigorate our conversation around individuals who are incarcerated and really make sure we understand the scenarios in which Medicaid can and cannot reimburse for services provided to those individuals. And so for the past couple of years, literally couple of years, we have been working on issuing some updated guidance that will not only pick up where we left off in 1997, but really kind of resets the landscape, given the change in the healthcare landscape since 1997. And so we are close, so close to having that guidance on the street. It would have been perfection if it had been released today. We often do not operate in a perfect world. So I would look for that to come out early in 2016. And I will be more than happy to continue this conversation with you all when that is in the public domain and I can answer your questions a little more straightforwardly. But the guidance will walk through a couple of broad categories of clarification. We'll walk through the term an inmate of a public institution. So who is an inmate? What kind of public institutions are we talking about? We'll walk through the exception to the exclusion that allows Medicaid to pay for inpatient medical care costs. And then we're also going to spend a lot of time talking about the gray areas between an individual who was fully incarcerated and an individual who is either on parole, probation, or has been released. And so individuals who are in a setting that could be called a halfway house, a setting that could be called a supervised residential facility. That has garnered an awful lot of policy discussion, both within CMS and with our partners in the Department of Health and Human Services and the Department of Justice as well, as the federal government has worked as a whole on all sorts of reentry initiatives and making sure that we are, as Secretary Castro said, trying to reduce or remove barriers to a successful reintegration into the community. We are determined to do that. Again, in the Medicaid space, within the context of having a payment exclusion that is built into our statutory framework. So that guidance will come out in the next couple of months, and I look forward to being able to continue that conversation. In the meantime, there are things that can be happening now, whether your state has expanded Medicaid or not. If an individual is on the Medicaid rolls and becomes incarcerated, nothing happens to his or her eligibility for the program. It is not an eligibility exclusion. It just means that the federal government cannot pay for services provided to that individual during his or her period of incarceration. And there are things that state Medicaid agencies can do to facilitate when an individual is released, he or she getting linked back into their Medicaid eligibility quickly. States can be suspending someone's Medicaid eligibility rather than terminating their Medicaid eligibility. So the individual does not have to go through the process of reapplying for Medicaid when he or she is close to release or at the point of release. It's more like a system edit that the state can implement, darkening their eligibility during the period of incarceration and then re-upping it upon release. And then there's also all sorts of flexibilities available to states to make sure that individuals who are not currently enrolled in Medicaid, but who have attained Medicaid eligibility during their period of incarceration are actually and formally enrolled in the program, so that again, when they leave the correctional system, they are able to right away access whatever kind of health care they need, be it prescription drugs, mental health, substance use disorder treatment, whatever kind of physical or behavioral services the individual needs. And I would also say that there are particular components of the Medicaid benefit package that could be really helpful to individuals who maybe have not had access to health care in some time or are new to the Medicaid program. All sorts of care coordination strategies that are available and all sorts of flexibility at the state level to define who those individuals are going to be, who are going to interface with individuals who are eligible for Medicaid and are incarcerated, to make sure they get linked into the care that they will be eligible for, and to make sure that they can access providers of all different types of qualifications, again, many of them being at state discretion. So one suggestion I will leave you with in closing is to establish a relationship with your state Medicaid agency. They really are the linchpin of how a Medicaid program is structured in that state. There are a lot of decisions that they can make in terms of the services and benefits that are provided to beneficiaries, how they are going to interact with individuals who are incarcerated to facilitate their enrollment as release is nearing. And there are a wealth of information about how they see the Medicaid program rolling out in their state and how they see working with you all as well. I would encourage you to think about how you can partner with your Medicaid agency, and if you contact them and say, here's how we can help move the ball together, again, regardless of whether expansion has occurred, I think that will be a conversation that they are very receptive to. So please keep that in mind. Please also keep in mind that CMS is available to you to provide technical assistance. We typically go through our state partners, but we are also available to non-state stakeholders and making sure all the parameters of Medicaid reimbursement are understandable. So again, I look forward to continuing the conversation when our guidance is out, and thank you very much for including me. Thanks.
Great. Well, thank you. We will look out for the guidance, and thank you for the tip about the technical assistance that CMS offers. I'm going to turn it now over to you, Gabrielle. You've been working nationally to help ensure that federal health care reform is something that people that are coming out are really taking advantage of. And so I'd just love to get your take on how that's going. How are we doing in that area?
Sure. Thank you so much. And again, very, very appreciative to Council of State Governments Justice Center for having me here, and to my fellow panelists, very excited to talk about this work, which I would say the biggest kind of challenge of this time is the amount of opportunity and the amount of change that's out there. And I should say I'm Gabrielle de la Gueronniere with the Legal Action Center. We are a 40-year-old nonprofit law and policy organization. We're doing a lot of work at the intersection of health and justice as we advocate for people with addiction histories, criminal records, HIV, people with mental health conditions. We're doing a lot of work to ensure that the Affordable Care Act is well implemented for people with mental health and substance use disorder service needs, and also for all those in the justice population. So very, very excited and happy to be here with all of you. I'll also put in a plug. Many, many thanks to the Bureau of Justice Assistance for continuing to partner with us to support criminal justice practitioners, such as all of you, around health reform. We do a lot of work with the Council of State Governments Justice Center and other technical assistance providers to BJA. Again, we would like to be helpful. We love identifying innovative work that's happening in one part of the country, which could potentially be replicated by others. So very happy to continue to work with all of you. So in terms of what we're seeing and how we're doing, I think, again, the challenge is the amount of change that's happening at the federal level and in all of your states and localities. But there is such a menu of possible options and possible opportunities to improve coverage for justice-involved people and to improve access to care that I think we're again just kind of seeing this tremendous change and tremendous again opportunity here. A few things I would say: enrollment, which is really the foundational piece. We know that to get access to care, we need people to be screened for appropriate insurance programs. We need to have this be a routine part of what we all do. And as Melissa was saying, I think there's been a lot of confusion about with the requirement that federal funding can't pay for services while a person is incarcerated, except for that inpatient community hospital exception. There has been a lot of confusion at the state level about when they can screen for enrollment, for eligibility, and when enrollment can happen. But again, enrollment can happen at every stage of the criminal justice system. It does really require a look at a state's policies to ensure that this can happen. And I think a lot of states are, re-examining these policies in light of the number of people who are newly eligible for Medicaid and the federal dollars that could flow to support that person's care. So again, enrollment as kind of the first step. We're seeing a lot of work at different intercepts, different models of different types of organizations coming in to criminal justice agencies to do this work. A lot of your organizations who already, again, have relationships with the institutions are starting to do this work. So it's an exciting time. The goal of all of this being really ensuring that people are enrolled in coverage and that there is not interruption as they move throughout different parts of the criminal justice system and between the criminal justice system and the community. That kind of seamless enrollment is really the goal. The second thing I would note is the increasing kind of recognition of the role of peers and knowing that to ensure that people are getting enrolled in health coverage, there has to be a trusting relationship and there has to be health literacy and appreciation of why this is a good thing for that person and for his or her family. We are seeing, I would point you to the transitions clinic work, which is really exciting. It's also, we do a lot of work at Legal Action Center to ensure that there is good employment opportunity, that there are good employment opportunities for people with criminal histories. This could also be a really powerful model to, again, connect people to health care through formerly incarcerated people. Melissa mentioned a number of different initiatives that are connected to the Affordable Care Act that are really aimed at addressing the co-occurring chronic health conditions that people have. So looking at mental health, looking at substance use disorder, looking at other types of chronic diseases, and meeting those needs in a more coordinated way. The criminal justice population is, we believe, really ripe for this opportunity, and there are a number of states that have already moved ahead with the Health Home, the Medicaid Health Home Initiative. New York, in particular, is explicitly involving healthcare providers who work with this population, which we're very excited about. So I would draw that to your attention as well. And that's an opportunity not just for states that have expanded their Medicaid population under the Affordable Care Act. For those of you in non-expansion states, the Health Home Initiative, again, could be a great way to really engage with Medicaid, to engage with healthcare providers who are serving your folks. I would also mention, again, kind of underscore through the Affordable Care Act and other initiatives, work to expand access to mental health and substance use disorder care. We know that the Affordable Care Act does expand coverage to many more people. We also know that coverage for mental health and substance use disorder care is a required essential health benefit for many of the programs, for all of the programs that are under the auspices of the Affordable Care Act, and that those benefits have to be provided at parity. This is a huge shift because we know, again, justice-involved people, a significant portion of the population were uninsured. Many of them were not connected to mental health and substance use disorder care. And now we are really looking at the coverage expansion, but also the required benefit provisions that, again, hopefully will really allow for better access to mental health and substance use disorder care. The administration also, in light of the opioid crisis, is really looking at ways to improve access to care, particularly medication-assisted treatment, which has been a continuing challenge in the criminal justice system, which we hope will improve. I would also like to talk about the potential for InReach. This is a model that we've seen in a number of places. Because federal Medicaid can't pay for services while a person is incarcerated, it has been a little bit of a challenge to try to cobble together some funding sources, but we know how critical it is for people to have strong transitions between incarceration and the community, and that if the enrollment can happen and a person's coverage can be activated and ready when they walk out the door, and if they have relationships already with community-based care facilities, and if there can be a warm handoff where the person can really be introduced into that community-based care, again, immediately upon release, it will improve the likelihood, really increase the likelihood that reentry will be successful for that person. So we have seen a number of models where mental health and substance use disorder service providers will go in again and help people get set on their medications and get ready to receive services in the community. We know also we've seen some payers, we've seen some Medicaid managed care organizations go in to do the enrollment work and again connect people to care. So again, to strengthen the likelihood that will be a successful transition. So wanted to also highlight that as a possibility. The last thing I would mention is the potential for Medicaid waivers, and again, Melissa indicated some opportunities there as ways to test innovation, to really try to improve health outcomes, to try to look at some of the costs to the healthcare system as people are getting care in a not a very effective way, knowing that people often, because they don't have health insurance or because they haven't had relationships with healthcare providers, they will go and try to receive care in emergency departments, which we know, again, is not the most effective and most cost-effective way to receive good care. We know that there are ways to kind of test different innovations, again, to try to improve health outcomes and to decrease health costs. And there are a number of states that are redesigning their systems and looking at ways, again, to kind of test this out. And this is another piece for folks not in Medicaid expansion states that could be an option. We know New York and California just had large waivers that were approved that do include a number of provisions that would be important for this population. The Institutions for Mental Disease, the IMD exclusion, which precludes federal funding for people who are receiving care in a facility of 16 or more beds, mental health or substance use disorder services. There are provisions in both of these waivers, again, aiming to ensure that people can get their healthcare needs met in a more kind of comprehensive way and trying to look at a whole system of care to ensure that that level of care is available for people for whom that's clinically appropriate, there are some ways to kind of test out and see how that works. So did want to kind of highlight that. I think as others have said, I think that the most important things are to really understand the landscape in your state and to understand kind of what initiatives are already underway, which initiatives your state may be considering, getting to know some of the healthcare providers and stakeholders and advocates who are largely working toward the same people and working toward the same goals that you all are working toward. I think it's incredibly important to kind of understand what the situation is. We did a resource, which I'll just quickly plug on behalf of our BJA grant, that is a map of the country, and it has different profiles of health information that's aimed for criminal justice practitioners. So it's up on our Legal Action website. If you Google Legal Action Center, state map, health information, criminal justice, I feel that will work, but we'll also include that a link of that somewhere. Yeah. But all of those keywords, I think, would bring it up. But it at least includes some initial kind of foundational information as you're learning about whether your state is a health home state, who your Medicaid director is, who some of the decision makers are in your state legislature, who the providers are. We have connections to the state mental health and substance use disorder provider associations. I would also say the importance of collaboration, which I know Andy touched on, can't emphasize it enough. We are all consumed with many things and being pulled in many different directions. And if we didn't kind of meet as a community to divvy up the work and to ensure that different people are expert on different pieces of this, it's just not possible. So just would really, really encourage folks to intentionally collaborate around all of this. I think learning from the activities that are happening in other jurisdictions. Johns Hopkins recently did a study looking at enrollment work around the country in the criminal justice system. Would definitely highlight that to you. I think it's helpful, again, to really try to learn how this is working in other places and adapt it to make it work for your jurisdiction.
Gabrielle, can I ask you a quick question about that? Because that really just hits on, I think, a concern that many DOCs have currently. We spend a lot of time talking about implementing new screening and assessments. We talk about the number of people that aren't getting adequate, let's say, reentry planning. We want to expand upon that. And I know it looks like we can do enrollment at multiple places, but when does that actually happen? Who can actually do that before somebody returns to the community? Do you have any examples that you could share of what that actually looks like?
Sure. So I can say that in some places, it's a part of intake when a person begins their period of incarceration. There is screening, and again, if the person is eligible for Medicaid, they're enrolled at that point. And if they are in a suspension state, this could work where their Medicaid would be suspended during their period of incarceration. In some states that are termination states, the focus would be toward the end of the time the person is incarcerated, and again, as a part of discharge planning, this work would begin. Again, it's in a perfect world, we wouldn't have any delay and people would be covered when they walk out the door and able to get care immediately. We know that we're not quite there yet. So that's kind of one piece, but we know that the people doing it, sometimes it's corrections folks, sometimes it is people from the state Medicaid agency doing it, sometimes there are enrollment workers and assisters who are helping to do that work that are community-based organizations that play a role. There are a lot of, and then as I mentioned earlier, there are also models with payers who, again, kind of appreciate that these folks are going to be enrolled in Medicaid managed care and they want them to enroll in their plans. So there are a lot of different ways to do it, and that's just kind of at the reentry point. We also know that there are huge opportunities for diversion and really appropriate diversion as early as possible, even with law enforcement involvement before you're arrested or before there is a trial. Now with health coverage, hopefully there's a greater opportunity to divert, again, appropriately people away from criminal justice involvement and into the healthcare system. So a lot of different models.
Okay, great, thank you. Yeah. I wanted to take a time to throw up our responses for our poll. It's actually seems to be decent news that 54% of you all have seen either a slight or a significant increase in the number of people that are now have some form of health care coverage. Almost 13% no increase, and about a third of you don't know. And so I'd like to spend a little bit of time about that don't know response. And, you know, my gut is telling me that maybe we should be thinking more about data, as Andy had mentioned around housing. Is that the place where we should start to help move the process along for those jurisdictions in which we're not seeing a lot of healthcare enrollment? And if it is, what type of data should jails and prisons collect? Or maybe it's their behavioral health partner. Do you have any thoughts on that?
Sure. I can try my best. We'll see how. I would say first that there is, really a lot of the time and information gap, that even if folks are doing enrollment or kind of aware that efforts are happening, it's unclear kind of how many people, what the scope is. People may know about kind of their individual program and see if there's been an uptick, but there might not be the ability to kind of understand kind of across. And that goes to, I think, what Melissa was saying really about working with the Medicaid agency in your state and knowing that this really requires investment and leadership by both the criminal justice, corrections, decision makers in the state and the healthcare decision makers, and that systems have to be created to allow for those types of things to be shared. That's what I would say as a foundational thought, but I'm sure my colleagues might have other suggestions.
Is there data that's available through CMS that we could look at maybe through the state Medicaid office in terms of enrollment and as a baseline measure? Would that be helpful?
Yes, there is a pretty good amount of enrollment data that should be available at the state level and at the CMS level for individuals who are enrolled in Medicaid. We're starting to collect that information on the numbers of individuals who are enrolled in private insurance, and then we also have numbers who are in Medicare. But for the Medicaid, in the Medicaid context, we do issue periodic reports about eligibility and enrollment figures. In fact, I think we just issued a report last week that really tracks how particularly the states who have expanded Medicaid are doing, but also the states in which Medicaid has not yet been expanded. So knowing whether your state has in fact expanded Medicaid is critical to knowing the scope of Medicaid reimbursement that would be available, or the scope of individuals who could be eligible for the program and the resources available to them. And then even if you're not in a state that has expanded, understanding who your state makes eligible for Medicaid so that upon release, those individuals can be linked into care, I think is one of the most critical points.
Yeah.
And I would just add real quickly that in most all the initiatives that we have around supportive housing, there's the InReach type component that Gabrielle spoke to, and I think one of the things that we really work hard on with our provider partners is to do as much of that InReach as possible for a few reasons. One is figuring out applications for housing and those sorts of things. The other is kind of the relationship building, but as part of that is absolutely thinking about Medicaid enrollment. And so we do a lot of that, as Gabrielle said, through a number of different partners, but we certainly lean on our provider partners who do a lot of InReach, to be candid.
Mm-hmm. One of the things that I know folks are very interested in is leveraging federal policies to help sustain people in the community beyond the life of a particular reentry program. And so we know obviously Medicaid covers physical health care. You mentioned behavioral health services, but a lot of the work that we do also includes a lot of case management services. Is that something that Medicaid would also cover as well?
Yes, absolutely. It is an optional benefit under the Medicaid program, and so states would need to make a decision to cover it as a service. There is a targeted case management benefit that offers states a lot of flexibility in defining the groups of individuals who are going to be receiving the benefit. States could define a target group as individuals who are newly released from incarceration or individuals at risk of incarceration, all sorts of flexibility there. And the parameters of that benefit are such that there is a plan of care developed that not only assesses the individual's health care needs, but social needs, financial, housing needs, really whatever the person requires. Medicaid will not pay for those underlying services like housing, education, things like that, but we will pay through the targeted case management benefit for the case manager to link the beneficiary with those resources and to make sure those meetings are happening and the individual is actually accessing the care that he or she needs. So targeted case management has been around for a long time, but it's really a pivotal activity that can really move the ball in terms of making sure the individual makes all those various touch points. And then there are some other variations on that theme of care coordination that either are new with the Affordable Care Act or have been part of the Medicaid framework but really haven't been historically used as much as they could be. And we're very happy to walk through those with you in your states. But do think about the targeted case management benefit because that really gets to the crux of making sure the person's needs are assessed and they get to the various providers of services that they need.
Great. Yes.
I would also refer folks, while CMS does not pay directly for housing, it was, I think, maybe this spring that they released a informational bulletin related to Medicaid and kind of housing supports and services that can be covered, which I highly recommend folks look at because I think there's a lot of misunderstanding and actual opportunity to be able to finance some of these services and supports under Medicaid, and I know there'll be additional guidance as well, but I definitely think folks should look at that CMS guidance from the spring.
Great. Well, thank you. I really appreciate all of your thoughtful remarks, chock full of information, and so I really do encourage everyone to check out CMS, contact their state Medicaid office. Legal Action Center has a lot of resources on their website, state-by-state resources on what's happening around healthcare reform, and the Corporation of Supportive Housing. Again, lots of great information, and you'll see also examples of what some of this data collection really looks like, and you're going to read some more about what the promising models look like as well. With that, I mean, sometimes it can feel really heavy to talk about housing and health, and there's so many challenges out there, but we really are at an exciting time. I mean, 5 years ago, we wouldn't be having this conversation. There's lots of opportunities out there. So with that, I hope all of you would just join me in thanking our panel here.